Hello, I'm Hope Rugo from the City of Hope Comprehensive Cancer Center, and on behalf of the Onco Alert Colloquium, I'm happy to present the best of the year 2025 for advanced triple-negative breast cancer. As we discuss these topics for 2025, it's important to keep in mind that I'm really just giving a very high overview of the phase 3 trials and don't have time to go into the smaller studies or sub-studies that looked at biomarkers and other considerations. Our topic really includes the rise of antibody-drug conjugates in the treatment of metastatic TNBC. ASCENT-04 looked at Sacituzumab govitecan in PD-L1 positive disease, and ASCENT-03 in PD-L1 negative disease, with TROP2-directed ADC looking at Datopotamab deruxtecan in PD-L1 negative disease. All of these trials moving these effective ADCs into the first-line setting and for metastatic disease. I'll give you a very brief overview of just a few of the new antibody-drug conjugates with new targets and new payloads that are being studied in clinical practice. So Sacituzumab govitecan is our starting agent, the first-in-class TROP2-directed antibody-drug conjugate. This was followed, of course, by Datopotamab deruxtecan, and now Sacituzumab Tirumotecan, or SAC-TMT, and we'll talk a little bit about a phase 2 trial that was done in the first-line setting with SAC-TMT as well. Sacituzumab govitecan, like the other three TROP2 ADCs, carries a topoisomerase inhibitor payload for SAC-govitecan, or SG. It's an SN38, which is the active metabolite of irinotecan. As you know, the first positive trial with SG was the ASCENT phase 3 trial that evaluated SG compared to standard chemotherapy in patients who'd received a median of 4 lines of prior chemotherapy, with mostly 3 lines in the metastatic setting, so heavily pretreated with few additional options. As you know, PFS and OS were both significantly improved with SG compared to standard chemotherapy. And we discovered by looking at biomarkers that TROP2 is expressed in all subtypes of breast cancer. The link with poor prognosis is unclear because the expression is seen in well over 90% of breast cancers that are triple negative and hormone receptor positive. We learned about the key grade 3 or greater treatment-related adverse events, which for SG largely are composed of neutropenia and diarrhea related to polymorphisms in UGT1A1 for diarrhea more than neutropenia. So, of course, it was, I think, a reasonable plan to move into the first-line setting, keeping in mind that treatment of metastatic TNBC remains a high unmet need. Recent data published in the Oncologist from community settings suggests that 30% of patients will actually die during their first line of treatment, and that only about 50% of patients will receive second-line therapy. My personal experience is that most patients do go on to second-line therapy, but this is the data from the larger community with insurance claims and other databases, and there are several papers suggesting that only a third of patients really are able to go on to second-line treatment. Therefore, the sequencing of therapy may be critically important for our patients to optimize outcome. So ASCENT-04 moved Sacituzumab govitecan into the first-line setting, but in a subset of patients who had PD-L1 positive disease by a combined positive score or 10 or more, which is the criteria for pembrolizumab based on the KEYNOTE-355 trial, which showed an improvement in both progression-free and overall survival with the addition of pembrolizumab to first-line chemotherapy. ASCENT used the same chemotherapy menu as used in KEYNOTE-355, paclitaxel, nab-paclitaxel, or gemcitabine and carboplatin, and used the same enrollment criteria of 6 months or greater since treatment in the curative setting, and prior anti-PD-L1 use was allowed, but only 4 to 5% of patients received prior immunotherapy in the early stage setting. About half of the patients were treated with taxane and half with gem-carbo as selected prior to randomization, and about a third of the patients had de novo metastatic disease, 34%. Also, just under 20% recurred between 6 and 12 months after completing treatment in the curative setting. And this is important because we actually have no idea that it matters if you separate 0 to 6 versus 6 to 12 months in terms of your clinical trial. And the reason for this division in ASCENT-04, excluding that first 6-month cohort, was simply because that's what KEYNOTE-355 do, but that was kind of an invented criteria. And I'll show you that TROPION-Breast02 included those patients, which I think is very important as we go forward in clinical trials. Patients who experienced blinded independent central review progression, which was the primary endpoint, were offered free SG as crossover in the second-line setting, but of course patients could receive drug off study as well. So progression-free survival by BICR was the primary endpoint, and this was significantly longer in patients who received SG and Pembro versus chemo and Pembro, as shown here, with a hazard ratio of 0.65. And impressively, at 12 months, 33 versus 48% of patients were free from progression, an absolute difference of 15%. By subgroup analysis of PFS by BICR, all of the subgroups appeared to benefit. The one group where you can see the confidence intervals widely crossing in the little circle at 1 is the 20 patients who had previous anti-PD-1 or PD-L1 therapy, but that number is too small to draw any conclusions at all. It also looks like patients did a little bit better in terms of the addition of Pembro to SG versus chemo if they received Gem-Carbo versus a taxane. But again, because those numbers were identical, it really wasn't powered in about a little over 200 patients in each group to really understand what those differences are. And it's likely that patients who received a taxane had more chemotherapy-sensitive disease and not primary resistance to taxanes. So it's a little bit hard to know, and you can't draw any conclusions. In terms of safety, we were surprised, I think, to see that the neutropenia risk was identical between SG versus standard chemotherapy. There are differences in toxicity in terms of higher grade diarrhea, an 8% increase with SG as we would expect, and more thrombocytopenia and neuropathy associated with the standard chemo because of the carboplatin and taxane. We were also happy to see that there was no increase in immune-related toxicity when patients received pembrolizumab with SG versus chemotherapy. This was exactly as you would expect to see. Objective response rate was relatively similar, a small difference here, but the complete responses were numerically higher in patients who receive SG. Importantly, because of this crossover, 81% of patients who received any subsequent treatment on the control arm with progression received SG. So this is really an important trial to tell us more about sequencing of effective ADCs in the triple-negative metastatic setting. There was a longer duration of response by 7.3 months, really remarkable, associated with treating with SG versus chemotherapy. So the responders did remarkably better than we've seen with any other therapy in the first-line setting if they received SG with their Pembro. So this is a potential new standard of care for patients with untreated PD-L1 positive metastatic TNBC, and overall, there was similar toxicity to current standard of care and good for our patients in terms of subsequent therapy, no cumulative neuropathy or ILD. The caveats is this very low percentage of patients who received early-stage pembrolizumab due to the timing of the study and geographic access. Understanding the impact of the 80% of patients who receive subsequent SG in the control arm will be of importance, and overall survival is still immature. There is strong support for allowing crossover, and it impacts assessment of overall survival, but I think we need to accept this impact and use surrogate markers, maybe PFS too. We want to offer the best treatment options for our patients who participate in clinical trials, and this is a very important issue moving forward. So what about moving SG into the first-line setting in patients with PD-L1 negative disease? So this trial, like TROPION-Breast02 or TB02, allowed patients who were PD-L1 negative or ineligible for PD-L1-directed therapy. So in ASCENT-03, only 1% of patients had PD-L1 positive disease, so it's really minimal. Patients were randomized to the same treatments without pembrolizumab if they had PD-L1 negative disease, as we saw in ASCENT-04, using that Keynote 355 chemotherapy regimen. And again, eligible patients with BICR verified progression of disease were allowed to cross over to SG. Very important. Patients still had to be 6 months since treatment in the curative setting, and they were allowed to have stable CNS metastases. If you look on the right-hand side, you can see that about 50, almost 60% of patients had received taxanes in the neoadjuvant or adjuvant setting. And again, only 5% of patients had received a prior PD-L1 inhibitor. So very important when we think about these patients. The median follow-up for this trial, I just want to show you, and similar to ASCENT-04, is just 13.2 months. So it's a really short median follow-up. And regardless of that median follow-up, as you can see here, the median progression-free survival was significantly longer in patients who received SG versus chemotherapy, with again about half of the patients receiving a taxane and half Gem-Carbo. And again, at 12 months, the difference in PFS at 12 months is really striking, 24 versus 41%. quite remarkable, a 17% absolute difference there, which I think is very clinically important for our patients. Again, the response rates were relatively similar in this patient group, potentially due to the chemotherapy used in the control arm. The median duration of response is longer, 7.2 to 12.2 months, so a 5-month absolute improvement in median duration of response. And the median PFS2 was longer in patients who received SG first versus chemo. And I think this is an important surrogate marker when you have crossover. A 4-month difference in PFS2 suggests that the sequencing may be important, that giving the TROP2 ADC in the first-line setting is better than holding off and giving it in the second or greater line setting. Again, if you look at these, the patients in terms of the forest plot, you can see that pretty much everybody benefited. There is a group of patients who received gem-carbo where the curve is a little bit to the right, but again, as well as the older patients. But again, there's no powering for looking at these subsets. In terms of safety, again, appeared to have what we would expect in terms of safety, and median treatment duration was longer in patients receiving SG. One thing of note is that there were some deaths associated with treatment, and you can see that there were treatment-related deaths, 6 versus 1 patient. Remember the randomization, so it was 2 versus less than 1%. These patients all died of febrile neutropenia or septic complications and did not receive growth factors, a critical message. We need to give growth factors to patients who are neutropenic and also have some GI toxicity because the mucosal barriers are disrupted, and this is critical. Overall survival is still early and obviously may be affected by the 82% of patients who initiated subsequent treatment from the control arm and received SG. Again, the median follow-up is short at just 13 months, so this is not mature as yet. So what about TB02? Well, this trial used a similar design. Patients were randomized to receive Dato-DXd, the second TROP2 ADC, given every 3 weeks versus day 1 and day 8, every 3 weeks for SG, compared to treatment of physician choice. But here the menu is different. You could get a taxane, you could get single agent CAPE or carbo, or eribulin. And it's important to keep in mind that of this group, 82% of patients received taxanes, but they did include patients who had recurred between 0 and 12 months. And that represented about 20%, a little under 20% of the total population, with 15% having a recurrence within the first 6 months. So it's likely that that patient population would not be very sensitive to taxanes as they would receive them in the early stage setting. And this is important as we look at the data in just a moment. Most of the patients had visceral mets in both trials, as you would expect, and the rest of the data we've reviewed. Here you can see the improvement that is highly statistically significant, favoring Datopotamab deruxtecan versus standard chemotherapy, with an absolute improvement of 5.3 months and a hazard ratio of 0.57. Also, overall response was markedly increased, and it's important to keep in mind that this overall response in the standard therapy arm, the difference was both PR and CR is quite low at 29%, and much lower than what we saw in ASCENT-03 in the control arm. And then overall response was much better with Datopotamab. So whether this has to do with the type of chemotherapy that patients received in the control arm, or whether this is truly a different population, remains to be seen. One of the things that's important is that we do believe in preclinical data that shows that adding a checkpoint inhibitor to ADCs may result in a superior efficacy compared to giving it to chemotherapy, and 10% of patients in TB02 had PD-L1 positive disease but could not receive a checkpoint inhibitor. The duration of response was longer, as shown there, very similar to ASCENT-03, 12.3 versus 7 months, but the overall response was higher, which it wasn't in ASCENT-04, but again, the control arm had a much worse overall response rate compared to ASCENT-03. As you can see, looking at the different criteria in the forest plot, all were better. This didn't separate into various types of chemotherapy. Overall survival with this follow-up is interesting because the follow-up is much longer in TB02 than it is for ASCENT-03, and I'll show you that in just a moment. And at this point, median overall survival is longer with a hazard ratio of 0.79. We tend to see this hazard ratio in many settings, statistically significant, and overall survival appeared to be better with a lot of confidence intervals that crossed 1 in a number of different groups. The only group that had a confidence interval that did cross 1 were those prior disease-free interval of 0 to 12 months, a hard-to-treat subpopulation, and we don't really know if those patients went on to receive next-line therapy. The toxicity for Datopotamab deruxtecan, or Dato-DXd, is different from SG. You see less neutropenia, but you do see oral mucositis, stomatitis, and ocular surface events, including dry eye, keratitis, and conjunctivitis. And you can see that there were grade 3 events. And if you looked at stomatitis in grade 2 and 3, which bothers patients, that was 34%, so a third of the patient population. Ocular surface events also, when you get to grade 2, where it bothers patients more, you're seeing that this is 23%. So these are toxicities that need to be managed. There were no adverse events in either arm associated with death, and very few patients in both trials discontinued therapy. There were more dose reductions and dose interruptions with the ADC. So sequencing clearly matters. We should incorporate this routinely into phase 3 trials, because this is going to help us understand the order, the appropriate order for all patients, and also understand impact on overall survival. But the approach is faced with significant challenges, including cost, need for drug production, and data interpretation. This shows you a summary of the 2 different trials, and I think the median follow-up is intriguing. It was 13.2 months for ASCENT-03 and 27.5 months, so more than double the time for TB02, and that did give them a more mature survival analysis. In terms of ADCs post-production, I told you 82% in treatment in patients who received subsequent treatment, and about 40% in a personal communication with the primary author of TB02, Rebecca Dent. Median overall survival data are shown here, relatively similar overall, but a shorter median overall survival in the control group for TB02 than in the control group for ASCENT-03, and it shows you the hazards of cross-trial comparisons. And again, median PFS is shown here as well. So really fascinating data. And I think what we see now is a new paradigm for treatment of metastatic TNBC for 2026, still including clinical trials, but really moving the ADCs into the first-line setting for both PD-L1 positive and PD-L1 negative disease. For patients who have germline BRCA positive disease, PD-L1 positive, we would use the Pembro combination with SG first and then PARP inhibitors. For patients who have PD-L1 negative germline BRCA positive disease, I think PARP inhibitors, if patients don't have visceral crisis, are a very reasonable first step in treatment. So a lot of changes to look forward to. SAC-TMT, as I mentioned, is the third TROP2 ADC in phase 3 trials. It uses also a topoisomerase 1 inhibitor, a belotecan derivative, and has a high drug-to-antibody ratio of 7.4. A phase 2 trial looked at first-line setting. A previous phase 3 trial, similar to ASCENT, showed improvement in PFS and OS in China. This trial, also conducted in China, looked at SAC-TMT in 41 patients, and again, similar criteria. This was regardless of PD-L1 positive or negative disease. And what they saw was a very nice response in the 71% rate, and also a long duration of response of 12.2 months, so very encouraging. This drug now has moved into the first-line metastatic setting in phase 3 trials, but at a lower dose. SAC-TMT in these trials had resulted in stomatitis, neutropenia, both, and some eye toxicity at 4 milligrams per kilogram, where the China studies were done at 5 milligrams per kilogram, both given every 2 weeks. So far, these toxicities have not been seen in terms of higher dose reductions or discontinuations. So studies are going on with or without immune checkpoint inhibitors in both PD-L1 positive triple negative disease and PD-L1 negative triple negative disease. In PD-L1 positive triple negative disease, Datopotamab deruxtecan is being evaluated with durvalumab and by itself, interestingly, compared to investigator choice chemotherapy with pembrolizumab in TROPION-Breast05. So a number of different studies to look forward to in the future. And we're very interested in sequencing, of course. Can you give a second ADC after a first ADC? Data from that presented by George Sledge from a large database from Caris looked at SG followed by TDXD or TDXD followed by SG in time to next treatment, because you can't really look at PFS in these large databases. And interestingly, it did appear that SG was better than TDXD first in patients with triple negative disease, with all the caveats of these retrospective studies, but it was a large database. So there are a number of studies looking at TROP2 ADCs and the HER2 ADC TDXD, the TRADE-DXd with Dato-DXd and TDXD, the series trial looking at SG followed by TDXD on patients who have hormone receptor positive HER2 low disease, and then the ENCORE trial by my colleague Laura Heber looking at SG and TDXD in either sequencing in prospective cohorts. There are new types of drug conjugates that I'm very excited about. One I just thought I would mention, this is a peptide drug conjugate. They're called bicycles because of their shape, as you can see on the upper right-hand side. And there could be many different bicycle medicines. And the first is Zelonectide Pevedotin, which is a Nectin-4 targeted ADC, so a new target, and it has an MMAE payload, which is a microtubule targeted, so different from the Topo1 targets. And Nectin-4 is amplified in about 20% of HR-positive, HER2-negative disease, and thought to be amplified in a much higher number of patients with triple-negative disease, and there's ongoing phase 1b/2 studies. Iza-Bren is an EGFR HER3 bispecific that's also being tested, a very interesting drug from BMS. And then there's a B7H4, this is an immune effector molecule with a topo-1 isomerase payload called Emily. And this has shown clinical activity in patients with B7H4 high triple negative breast cancer, presented at ASCO this year. The company, Mersana, has been bought by another company, and we're hopeful that the studies will open up early this year, and continuing to study this fascinating ADC in triple negative and, of course, hormone receptor positive disease in the future. So can we further improve efficacy with new antibodies? There's very great interest in bispecific immune checkpoint inhibitors using both targeting of PD-1, PD-L1, and VEGF to try and improve the anti-tumor efficacy. There are two main agents that are being studied, but many others: ivonescimab, an anti-PD-1 VEGF bispecific, and pumitamig, which is an anti-PD-L1 VEGF-A bispecific. These drugs actually have shown efficacy in early phase trials. There's one ongoing phase 3 trial called the Rosetta trial, randomizing patients to this antibody, pumitamig, with standard chemotherapy versus placebo and chemotherapy in patients who have PD-L1 negative metastatic disease in the first-line setting. Of course, this has to compete with the increasing use of TROP2 ADCs in the first-line setting. So what has changed in clinical practice? ADCs are moving into earlier lines of therapy. Preferred ADCs with phase 3 data are TROP2 ADCs with a topoisomerase payload. There is data with T-DXd in previously treated triple negative HER2 low disease, but this included only 58 patients. So I think we would use it subsequent to a TROP2 ADC, depending on the sequencing study results, rather than first line. There may be some difference in what we would do in patients with refractory brain metastases, since we have more data with T-DXd in brain metastases. As first-line therapy, these ADCs improve PFS and duration of disease control, and there is data with overall survival benefit with Dato-DXd without a full crossover in all the patient population. So understanding the sequencing is still a big topic for us. We don't know what the impact of neoadjuvant or adjuvant pembro is in the combinations with pembrolizumab, regardless of what toxin agent you use. And toxicity management is critical to maintain the benefits and efficacy. No patient should die from neutropenic sepsis without receiving growth factors. So as we move forward, we're going to learn a lot more about sequencing, and I'd like to thank you for your attention. And I'm showing you sunrise on the top of Haleakala in Maui in Hawaii, because that's where we really are in the treatment of metastatic triple negative breast cancer. The sun is rising. Thank you.